Today, we will be speaking about object recognition and the clinical manifestations of visual agnosia. This presentation was created by Jacob, Isabella, Mayar, Maya, and Lucy. Object recognition describes the process in which our brain perceives and recognizes the world, whether this involves recognizing a friend in a crowded room, reading words on a piece of paper, or looking at old photographs. Our ability to visually recognize objects in various situations, then classify them into specific categories, requires a complex interaction of many different brain structures.
Agnosia is a disorder in which a patient is unable to recognize and identify objects, persons, or sounds using more than one of their senses, despite otherwise normally functioning senses. This deficit cannot be explained by memory, attention, language problems, or lack of knowledge of stimuli. Agnosia usually affects only one sensory modality, for example, being unable to identify an object by sight, although being able to identify it through shape and texture. The two classical forms of agnosia are apperceptive agnosia and associative agnosia. Apperceptive agnosia is the failure in recognition due to deficits in early stages of perceptual processing, while associative agnosia is failure in recognition despite no deficits in perception. Typically, associative agnosia patients can draw, match, or copy objects, while apperceptive agnosia patients cannot. The three main types of agnosia are visual, auditory, and tactile. For the purposes of this presentation, we will focus on visual agnosia. Visual agnosia is an impairment in recognizing visually presented objects, despite otherwise normal visual field, color vision, brightness discrimination, acuity, language, and memory. This is the most common and better understood agnosia. However, patients can still recognize objects using other sensory modalities, for example, identifying an object by touch only, but not sound. Impairment can vary between objects, therefore a variety of objects may be needed to diagnose. There are two subtypes of visual agnosia, apperceptive visual agnosia and associative visual agnosia. Apperceptive visual agnosia is an abnormality in visual perception and discriminative processing, despite having no elementary visual deficits. This is associated with lesions to the parietal and occipital cortex. However, associative visual agnosia patients are characterized by difficulties in understanding the meaning of what they are seeing. This is associated with damage to the bilateral inferior occipitotemporal cortex. Apperceptive visual agnosia patients are unable to recognize objects, draw and copy figures, while associative visual agnosia patients have the ability to draw or copy, but do not know what they have drawn. Apperceptive visual agnosia patients cannot perceive the correct form of an object, despite having knowledge of that object. Conversely, associative visual agnosia patients cannot link a fully perceived visual stimulus to prior knowledge of that object in order to recognize it. There are many different diagnoses of visual agnosia. One example is prosopagnosia, which is the inability to recognize familiar faces. This results from damage to the fusiform face area. Patients still have some ability to derive facial information such as gender, hair, emotion, and age, although they struggle at identifying facial expressions.
How neuroimaging methods can be used to differentiate between types of visual agnosia. Now we will cover how neuroimaging methods, specifically EEG, can be used to differentiate between different types of visual agnosia. Most research into assessing the deficits of different types of visual agnosia is done through behavioral testing and functional and structural brain scans to examine the spatial extent of cortical damage. This gives researchers a clear idea about the temporal workings of visual agnosia in the brain, but neuroimaging methods with high temporal resolution have not been used to help assess the temporal profile of the deficits. In the article, Differentiation of Types of Visual Agnosia Using EEG, High and others used high-density electroencephalography, or EEG, to examine variations in the temporal dynamics of two individuals with visual agnosia. They believe the use of different neuroimaging methods would provide important insights into the temporal workings of the neural processing of visual responses in individuals with visual agnosia. Using electrophysiological approaches can allow examination into how early visual processing and damage to it assists in object processing, and can provide further insights into questions by assessing electrophysiological disturbances following brain damage. The use of EEG will examine visual responses of different visual agnosia and the use of decoding analysis to measure EEG responses to checkerboard stimuli. The frequency decoding analysis can illuminate where an individual's abnormal functioning is taking place in processing visual information and how visual information can be recovered when the damage is early in the visual stream. An advantage of using EEG decoding methods is the ability to measure a single individual's responses and compare them against the norm. This could allow for future uses for individuals by providing a more accurate identification system of the extent of brain damage in patients.
Based on previous research, it has been found that there exists a dual stream processing model that connects ventral occipitotemporal WET pathway along the dorsal occipitoparietal WHERE pathway. Those with optic ataxia have an inability of spatial recognition, yet those with visual form agnosia, also known as VFA, conversely find difficulty in recognizing objects. Some patients have this disorder due to carbon monoxide poisoning, but our patient, JS's ataxia, is a result of an acute stroke lesion. Using FLAIR imaging, patient JS's stroke resulted in a lesion constrained to the medial aspects of the ventral occipitotemporal cortex. We will now investigate the VFA of the patient JS after finding his shape and orientation perception, as well as the identification of real objects severely impaired in the following telehealth appointment.
Good morning, patient JS. Can you describe to me what occurred to you about 2 months ago, and what are the consequences that followed?
Good morning. By profession, I used to be a technical engineer, but 2 months ago, I suffered an ischemic stroke while I was getting a coronary angiography. It's frustrating. I can't watch TV, read newspapers, or even get dressed unless I already know where my clothing is located in the room. It's like I can't even visually identify items. I also have trouble recognizing my family members by their face and can only identify them by their voice.
All right, patient JS, thank you for that information and for completing our previous 2 experiments on perceptual discrimination on the irregular object grasping task and disc perceptual orientation task. As we already covered in this irregular shaped objects perception task, you used your index finger and thumb to indicate the size of an irregular shaped object that I presented in front of you and that you attempted to pick it up. Now, using the same index and thumb measurements as before, please attempt to pick up these rectangular shaped objects in front of you.
Okay, Doc, I'll do my best.
Well, JS, I have some results for you. It appears that when attempting to do the perceptual orientation test, your judgments were 46.8 degrees on average different than the healthy controls. In regard to the size estimation versus grasping of the rectangular objects, we actually found some correlation in your finger aperture and object size, yet still differed strongly to the control participants. For the perceptual discrimination versus grasping of irregular shaped objects, you were actually able to achieve correct responses 73% of the time. Yet we're still far behind the controls that were 97% of the time correct.
I see. So you're saying that my visuomotor performance was relatively okay, yet my perceptual discrimination abilities for the objects were significantly inferior to the healthy control individuals.
Yes, exactly. Our results from the 3 experiments, as well as the imaging studies with FLAIR, lead us to conclude that the medial structures of the ventral occipitotemporal cortex are integral to the normal flow of shape and contour information into the ventral object recognition.
Thank you for that, Doc. Hopefully now with this research, there might be some hope in investigating treatment options for people like me.
As we can see from JS's performances on the various visual and tactile perception tasks, the results show that JS's shape and orientation perception, in addition to his identification of real objects, are severely impaired, which is evidence for visual form agnosia. Other perception modalities, such as color and movement, were well preserved. FLAIR MR imaging of JS displayed damage of the medial aspect of the ventral occipitotemporal cortex, and the bilateral lesion from his stroke also included fusiform and lingual gyri and a narrow portion of the posterior cingulate gyrus. The anatomical findings in conjunction with the perception experiments suggest that medial structures of the ventral occipitotemporal cortex are vital for shape and contour stimuli to be transmitted to the perceptual ventral stream system for object recognition. While this case study shows excellent evidence of a clear anatomical finding indicating the role that the medial aspect of the ventral occipitotemporal cortex has in perceptual visual information processing without alterations of human motor control, nevertheless, since the brain is a distributed system as we discussed in class, patients with visual form agnosia who have diffuse brain damage as well as damage localization should also be studied. Additional studies involving investigation of the lateral structures of the ventral occipitotemporal cortex to determine their role in shape and contour recognition should also be considered and performed. While there is no specific treatment for visual form agnosia, neuropsychological rehabilitation and symptom support are clinical considerations for the neurological disorder.